Sorry, we are starting the paper session a little late. So can we start with Dr. Shruti Muralidharan? So I think each paper is going to be of 6 minutes duration, followed by a 2 minutes of discussion.
Done in cases to address pathology of both the cornea and posterior segment simultaneously. A temporary keratoprosthesis in such cases helps in visualization of the posterior segment. The anatomical and functional outcomes of such a combined procedure depend on several factors like the indication, the presence of infection, and ocular comorbidities. Tertiary care centers like ours have the multidisciplinary expertise of handling this relatively rare procedure. Ours was a retrospective case series where we reviewed case records of 12 eyes. These were pediatric patients who underwent a combined corneal and retinal surgery between the years 2020 and 2022 and had a minimum follow-up of 6 months post-surgery. While reviewing records, we grouped the parameters studied into preoperative, wherein we looked at the corneal and the retinal indication for which the surgery was done, the presenting visual acuity, and the associated ocular comorbidity. Intraoperatively, we looked at the type of keratoplasty done, that is therapeutic or optical, and nature of retinal tamponade used. And postoperatively, we looked at anatomical outcomes in terms of graft clarity and retinal status, and functional outcome in terms of postoperative visual acuity. So out of these 12 patients, the mean age was 9.25 years and mean follow-up was of 6 months. Of these 12 eyes, 9 had a traumatic etiology and 3 were non-traumatic. Majority of cases had a therapeutic graft done. The most common corneal indication was a corneal infiltrate, followed by corneal decompensation in congenital glaucoma, and the most common retinal indication was endophthalmitis, followed by retinal detachment and an epiretinal membrane in one case. Out of the 9 eyes belonging to the trauma group, 8 of them were infective and 1 was non-infective. All the infective eyes had a corneal infiltrate coexisting with an endophthalmitis. None of the eyes had a pre-op visual acuity better than hand motion close to face. Intraoperatively, retina was seen to be attached in 2 eyes. 2 of them had a retinal detachment, 1 had a retinal detachment with PVR changes, and 1 had a retinal detachment with choroidals. The most common organism isolated on microbiological examination was gram-negative bacilli. Post-operatively, at final follow-up visit, 4 of these 8 eyes were lost to phthisis. Of the remaining 4 eyes, 3 showed an improvement in visual acuity with moderately clear graft and an attached retina, while 1 maintained the same visual acuity as that pre-op, had a failing graft with an attached retina. None of these eyes had any preoperative ocular comorbidity, and silicone oil tamponade was done in all eyes which had a retinal detachment. 1 patient in the trauma group was non-infective. This eye had a corneal scar secondary to an open globe injury repair and had a retinal detachment with PVR changes. This eye also at final follow-up visit was ultimately lost to phthisis. The non-trauma group included 3 eyes, 2 of congenital glaucoma and 1 with congenital sclerocornea. 2 of them had a retinal detachment and 1 had an ERM. At final follow-up visit, 1 of these eyes was lost to phthisis. 2 showed an improvement in visual acuity than the presenting vision, had moderately clear grafts with an attached retina. Pictures A and B show pre- and post-operative images of a PKVR surgery done in case of traumatic endophthalmitis. This eye was ultimately lost to phthisis. And pictures C and D show a PKVR surgery done in a case of sclerocornea with bullous RD. Of these 12 eyes, 6 were lost to phthisis, 5 of which belonged to the trauma group and 1 to the non-trauma group. Of the remaining 6 eyes, 5 retained moderate graft clarity, while 1 was a failing graft, all with attached retina. Post-operatively, 5 eyes had better vision than the presenting vision, whereas 1 maintained the same vision. And the most common ocular comorbidity in these eyes was seen to be glaucoma. 2 of them had primary congenital glaucoma, which required trabeculectomy with MS glaucoma valve for IOP control. And 3 eyes had developed secondary glaucoma post-procedure, 1 of which required a diode cyclophotocoagulation and 2 required topical anti-glaucoma medications for IOP control. So there are published retrospective case series which have described such combined procedures with varying anatomical and visual success rates, but due to the difference in trauma-induced damage, it makes it difficult to exactly compare these different series. However, there is no published literature till date on pediatric PKVR procedures. Still, we managed to compare our case series with a few pre-existing case series, and we saw that trauma remains to be consistently the most common indication for such procedures. Our series had a 42% of eyes with a moderately clear graft and attached retina. However, the rate of phthisis was seen to be relatively higher in our series. Our series was also not without limitations, the most important of them being that this was a retrospective data, the small number of eyes included, and also the need for longer follow-up periods to ascertain outcomes better. So in conclusion, a combined PKVR surgery allows rehabilitation or preservation of eyes with severe ocular pathology. The functional outcomes of this procedure are limited by primary and secondary tissue damage as well as ocular comorbidity. And the anatomical success rates of 50% as seen in our series underlines the fact that despite confounding factors and technical difficulties, it is worth attempting to surgically intervene than lose these eyes to phthisis. Thank you.
Nice series, Shruti. And even if we can provide some iota of vision to these pediatric patients, it is very much beneficial to them in the long run.
Yes, ma'am.
So nice compilation of of cases.
Thank you.
Good. So our next speaker presenter is Khushi Shah, and her paper is on clinical evaluation of early corneal changes after phacoemulsification.
Good afternoon, everyone. I'm going to present a paper on clinical evaluation of early corneal changes after phaco. So as we know, all surgical procedures that involve entry into the anterior chamber damage the endothelial cells due to intraoperative corneal manipulations. After endothelial cell loss, the adjacent cells migrate, slide over, and compensate by polymegathism and pleomorphism, that is a change in the cell density and morphology. Central corneal thickness is an indicator of the physiological condition of the corneal endothelium. The parameters that can be judged are endothelial cell density, coefficient of variation, and percentage of hexagonal cells. An abnormal corneal endothelial cell morphology along with a raised CCT is a marker of endothelial cell dysfunction, which causes fluid imbalance, stromal swelling, corneal edema, and loss of transparency. So the aim of this study was to look for the impact of phacoemulsification with intraocular lens implantation on the endothelium of 100 patients over a period of 6 months. We have compared the pre- and post-operative corneal parameters amongst all patients and specifically between diabetics and non-diabetics to look for the effect of phaco power on the endothelium and to look for an association between the glycemic control and post-operative changes in parameters. So this was a prospective observational study and the patients were followed up to 6 months after surgery. The pre and post-operative CCT was measured by ultrasonic pachymetry and the corneal endothelial cell density, the hexagonality and coefficient of variation was measured using a non-contact specular microscope. The patients were followed up 1 day, 1 week, 1 month, 3 months and 6 months after surgery. The gender distribution was 55% of our patients were females. 18.81% diabetics had an HbA1c level less than 6.5, while 81% were more than 6.5. And the mean phaco power seen was 6.81 plus minus 3.35%. There was no statistically significant difference observed between the phaco power used in both the groups. Of all the patients, 18% were diabetics only, 15% were diabetics and hypertensives, and 51% had no systemic illnesses. This is the master chart of the data collected. So first, we look at the changes seen in the central corneal thickness. So the CCT increased after on the first day and gradually decreased till 6 months, gaining almost near preoperative values. But the fluctuations were seen more in diabetics, and the increase in the CCT was significant at the first day and first week after the surgery. If we look at the changes in endothelial cell density, then there was a marked decrease seen, which was the maximum lowest point was at 1 week after surgery, and the density increased gradually to attain almost near preoperative values, but a significant deficit was seen, and the deficit was higher in diabetics than the non-diabetics. changes in percentage hexagonality were also seen. It decreased, and the minimum peak was obtained at 1 month after surgery, and it increased to gain the near preoperative values with a higher variation in diabetics, and similar change was seen in coefficient of variation as well. So the endothelial cell density was statistically significantly decreased in diabetics with an HbA1c less than 6.5 compared to those with more than 6.5, and there was no statistically significant association seen between the endothelial cell loss and phaco parameters. The CCT measured by ultrasonic pachymetry as discussed had the highest value on first day and progressively decreased with the higher values in diabetics than non-diabetics. And the endothelial cell density with specular microscopy showed a higher deficit in diabetics, that is a mean cell loss of 4.55% compared to non-diabetics who had a cell loss of 1.05% over 6 months. Similarly, the percentage hexagonality and the coefficient of variation also showed maximum difference in the first month, and they almost regained the preoperative values with a higher variation in diabetics. So the endothelial cell damage is higher because of various biochemical mechanisms, and they are more susceptible to stress and trauma. So the conclusion is that preoperative screening of the cornea is essential by slit lamp and specular microscopy. Adequate viscoelastics must be used routinely also to prevent damage to endothelium due to inadvertent trauma by instruments, the solutions, phaco power, long exposure periods, etc. Mild cases of endothelial dystrophy should use good viscoelastics and consider for triple procedures in severe cases. Also, advances in surgical technique like torsional ultrasound, femto-assisted cataract surgery, better dispersive viscoelastics, and control of systemic illnesses like diabetics may prevent endothelial cell loss after cataract surgery. The limitation was that the sample size was small because a lot of patients could not come for follow-up, and the non-diabetics were not included as a control group. Thank you.
Khushi, yeah?
Yes, ma'am.
So you showed that the sample size was 100 and
Yes,
follow-ups you had of? all
6
100?
months of all of
Of
these
all
patients.
100.
But we aimed for a higher number of patients, but 100 could come for a visit.
Do you know what was the power of the study with 100?
I have not
What was the
calculated
original sample size that you had expected to get a good power?
Ma'am, around 150.
Okay, so not too bad. then,
Yeah,
even
not
if you've
bad.
got
Yeah.
100.
And it was the patients were the cases were taken up to 2 years. We were monitoring the patients, and we were the duration was 2 years. Out of them, only 100 could come for 6 months. That's why compared to the number of surgeries that were performed in 2 years, the sample size was.
So do you think you are, by doing this study, I saw your conclusion slide,
Yes.
but are we going to change our practice in any way than what we already are doing? Because like we saw the discussion also,
Yes.
most of the things are
Most of the
already
things
known,
are
isn't it?
followed. It is just like evidence-based medicine.
Okay, so you just wanted to see in your
proof.
population how
Yes,
it is
ma'am.
happening. Okay.
And do you advise cataract surgery in diabetics more HbA1c more than 6.5?
Ma'am, we aim for control. If required, even insulin, and the patient is admitted and given
80% of your
insulin.
patients had a
Yes, ma'am.
uncontrolled HbA1c.
Yes, ma'am. Yes, ma'am. But after control, they are taken. But the HbA1c more than 6.5, but they had a good control FBS and PP2BS, and they were on oral hypoglycemic agents.
Okay.
So, like Rashmi said, that apart from this, no new message, right? You just
Yes,
wanted to study it in your
Yes,
own.
ma'am. To look for what we read is actually what we find. Thank you.
Thank you.
Sharon is not here. Shalini, we have to call in the end.
Dr. Sharon.
So it's written that we should call you in the end. Do you want to come and present now? That's Shalini. Take it.
So we invite Dr. Shalini Singh for her study on retrospective design of demographic profile and long-term outcomes of DSEC in AGVIs.
A very good afternoon, everyone. I am Shalini Singh and I'll be presenting outcomes of DSEC in eyes post AGV implant surgery. Corneal edema following glaucoma surgery is one of the most common indications of endothelial keratoplasty, comprising of both trabeculectomy and implants. In one of the recent study by Das et al., it has been reported that DSEC is one of the most common performed endothelial keratoplasty, and corneal decompensation post-glaucoma surgery accounts to about 3.27% of these cases, and including eye syndrome, the percentage goes up to 5%. Penetrating keratoplasty in this paper by Rahman et al., glaucoma has been reported as one of the most common complications and recalcitrant one, difficult to manage just with medical management. Later on, Linio et al. Reported that glaucoma drainage device in itself is a high risk factor for post-keratoplasty patients. And then there were many reports which were discussing the complications and the risk factors of keratoplasty post-glaucoma surgery. Why is it difficult and what is the cause for corneal edema post-glaucoma drainage device or Ahmed glaucoma valve in general? Mechanical rubbing or indirectly even the flow turbulence around the GDD tube causes corneal edema locally. The glaucoma drainage device allows air to escape, hence making difficult to get the air tamponade, leading to lenticule detachment. Post-glaucoma drainage device, there is more predisposition for formation of anterior synechiae, multiple surgeries done in the past, and in general unhealthy aqueous humor composition, that is more proportion of inflammatory mediators, leads to corneal edema. So the purpose of this study is to evaluate the demographic profile, outcomes of DSEC graft in AGV eyes, and analysis of risk factor for graft failure at a tertiary eye care facility. It was a retrospective study, and patients who underwent DSEC with AGV tube in place from January 2011 to December 2022 were included. A total of 67 eyes of 67 patients were found, out of which 37 patients underwent DSEC after Ahmed glaucoma valve, and the number of surgeons who performed these surgeries were 4. Exclusion criteria: patients who underwent DSEC before AGV, glaucoma drainage device other than AGV, and patients who had a follow-up duration of less than 3 months. Data which was collected in this study was the age, gender, indication, pre-op and post-op visual acuity, position of the tube and tube trimming done at the time of DSEC or even later, endothelial cell loss, AGM used pre-operatively and post-operatively, and the IOP control. Primary outcome in this study was DSEC graft survival post AGV eyes and the risk factors for graft failure, and secondary outcome to see if there was any effect on the AGV post DSEC. DSEC was a standard operating procedure where eye bank prepared donor tissue was used. Tube trimming was done in few of the cases where mechanical rubbing of the tube was noticed, and graft was inserted into AC using Sheath's IOL glide. Post-operative management comprised of noting the best corrected visual acuity, slit lamp examination, tonometry, topical broad spectrum antibiotics and steroids were started on post-op day 1, and steroids were gradually tapered and maintained at once or twice daily. So coming to our results, as you can see, age, the mean age was 49.57. Coming to gender and laterality, there was almost equal distribution among males and females. The type of glaucoma and the reason why Ahmed glaucoma valve was done, as you can see from this table, that the majority of the patients had secondary glaucoma, could be because of steroid-induced angle recession, post-keratoplasty patient, or glaucoma associated with complicated cataract surgery. Post-op complication, only one of our patient has a severe AC reaction with hypopyon. The most common complication we came across and which is expected is lenticule detachment, which was seen in 32.4% of the patients. So graft failure noted, 14 of our grafts failed and 23 maintained a clear graft. Median follow-up duration was around 2 years. Risk factor analysis for graft failure. This table very clearly shows that most of the factors did not seem to have an impact on the survival of the graft, although the duration between AGV and DSEC. Most of our patients underwent DSEC at least 1 year post AGV, but around 11 of our patients underwent DSEC even within less than 1 year, because these patients had minimal amount of corneal edema even when DSEC was done, and this seems to have a significant effect on the survival of the graft. Percentage loss in AGVI, some of our patients had significant endothelial cell loss after DSEC, which was around at 6 months 3%, and at 4 years it was up to 74%. This is a Kaplan-Meier survival analysis which shows the probability of graft survival and which clearly shows that none of the specific indications seems to have a protective effect on the survival of the graft. Coming to graft survival in general, most of our grafts, as you can see, till around 2 years, 75% of our grafts were doing well, but progressively up to 6 years, the survival of the graft declines severely. The secondary outcome of this study was the risk of glaucoma worsening of the DSEC. So there has been many studies which shows that AGV is noted to have a better IOP control in post-keratoplasty eye. In our study also, it has been seen that the IOP control is much better in post-keratoplasty eye. When compared to other studies, we can see that our population had a younger age group and IOP control was better with AGV in comparison to other studies, whereas graft survival, mean survival in our patients was 6 years when compared to Schoenberg and Kang et al., where they showed a survival of 2 years. So to conclude, IOP control before DSEC is crucial. Donor graft with a higher endothelial cell count, and GDD is noted to be a safe and better alternative to IOP control. Thank you.
So you noticed that the patients who had a graft, who had a DSEC less than 1 year were more prone to failure?
Yes. So there were like around 11 patients in whom we had to do before 1 year, but these patients did have minimal amount of edema even when AGV was being done in them. But yes, the graft survival with each year, the duration between AGV and DSEC, we noticed that the hazard ratio decreases significantly as you grow. The distance between AGV and DSEC increases.
So your paper will add that we should delay the...
Yes, this has not been reported before. This was one of the additional findings which we noticed in our paper.
So this is not related to your study, like this is the AGV being done prior to the DSEC, right?
Yes.
So any thing that you've noticed, any similar findings when AGV done post DSEC?
Regarding the duration?
No, I mean, what about the status of the graft if the AGV is being done post DSEC?
Regarding IOP control, AGV, as I said, even for this, and when I have done review of literature, we have noticed that IOP control in post-keratoplasty eyes when compared to trabeculectomy or medically managed, AGV provides a better IOP control. Graft survival previously, which have been reported in, like if the AGV is done after DSEC, it does not seem to affect the survival of the graft, even if it is done after keratoplasty has been done. One important finding which has been reported recently in 2022 by the Australian group is that penetrating keratoplasty has a better graft survival when compared to endothelial keratoplasty in post-tube eyes.
Good, thank you. So we can call
the premise of your study is basically the IOP should be controlled and only then a graft should be done?
Yes.
Else the graft can fail?
Yes.
Thank you.
Thank you.
Sure.
Okay, next we have Dr. Sharon D'Souza for Stepping Stones to Success, assessing the integration of iPSC-derived corneal endothelial cells on ex vivo model.
Good afternoon, everyone, and thank you very much for this opportunity to present our work. So we all know that the endothelial layer is very critical in maintaining the corneal transparency and its pump and barrier functions. And of course, conditions like Fuchs dystrophy or corneal trauma can affect this. There have been a number of papers which have shown what are our challenges. Even though we can do corneal transplantation, there is always a global shortage of available transplantable tissue, and possible graft failure even exists even with endothelial keratoplasties, although much less. So what we are trying to understand is what in these decompensated corneas, we know that the treatment is endothelial keratoplasty in the early, when we can without scarring. But because of the global shortage of tissue and problems related to this work, we want to know if there's any way to bypass this. And there has been a lot of work which has gone around all over the world about generation and transplantation of corneal endothelial cells. And of course, we all know the landmark work of Professor Shigeru Kinoshita and his team, which have been over the last 20 years. So the challenges with the existing way of expansion of endothelial cells is, if we are trying to generate the cells from a corneal endothelial phenotype, we know that they are not normally cells which divide. So there's a limited expansion of the cells there. And of course, it needs a lot of technical expertise, as with all the generation systems. And once we have generated this, then we have issues with transfer and viability, which I'll come on. So the plan of any such kind of work would then depend on how we generate the induced corneal endothelial cells, how we integrate it to a substrate or directly into the cornea, how do we maintain it in terms of morphology and function. Are there any alternative approaches from the way that we are looking at? Then we can move into animal experiments, clinical trials, and then bench to bedside. So our work till now, which I have presented last year, was that we have successfully generated the corneal endothelial cells from pluripotent stem cells. And how do we say that they have the endothelial phenotype? So peripheral blood cells, which are just taken from a normal blood sample, were reprogrammed to form pluripotent stem cells. And by the name, we understand that they can be then moved to whichever kind of corneal morphology or cell morphology that we want. And over multiple passages, we move them from neural crest to the corneal endothelial cell type. And then we characterize this by RT-PCR and immunohistochemistry. So this was what we had shown, that you can actually get the proper endothelial phenotype, which is the normal hexagonal pattern that we actually saw to be existing in the lab. But that's not enough. We also saw the functionality of it, which was the zonular occludence marker, which is the paracellular barrier, and the sodium-potassium ATPase pump, which is the functionality as we know. So how do we go forward from there? We wanted to know now if we can move to the integration of the corneal endothelial cells from the induced pluripotent stem cells. So what we did was, we took ethics committee, we had 10 cadaveric eyeballs, and using an aseptic technique, we then moved forward. So from the cadaveric tissue, we have to do an atraumatic denudation of the endothelium as shown in the video there. And we did two things. In one, we transplanted the cells directly into the eyeball, and after a 7-day incubation, we cut the button. And the other, we cut the button, then put the cells and incubated in organ culture. And I'll tell you why this was important. We then, after that period of incubation, moved to the markers for the similar markers which we had already shown to be important to characterize the endothelial cell phenotype. So what was very interesting was that in the globe, we didn't find too many changes. The cells don't seem to be forming. But when we did it in the corneal button, we found that before, this is just a specular of the corneal button, before the endothelial cell removal, you can see the normal cell morphology. Then after this, I'm sorry for this typo, after the endothelial cell removal, there are no cells which are visible. And then after we put in the induced corneal endothelial cells, you can see that there are a few cells which are showing. The reason that not more cells are showing is because the period is only 7 days, and the zonular occludence doesn't have time to mark, or the cells have not grown to form their normal hexagonal morphology. We also then looked at the same markers in the cornea to see the integration, and you can see that the decellular donor cornea does not have any ZO1 marker, but once we've transplanted it into that, it has shown integration, and you can see the marker for the zonular occludence, which shows that those cells are now getting integrated and they are also functioning as endothelial cells. This is another very important, the sodium-potassium ATPase, which is of course our endothelial pump, also showed the similar markers where even after integration, it is functioning as its normal endothelium. And non-muscle myosin is a very important expression of our myosin, or the muscular changes there close to it, and also is a very good marker for endothelial morphology, which also showed expression of this. So how does this add, or what do we know from it? It's been done from somewhere. What has been done is usually from a corneal endothelial phenotype. There are very few groups working to get it from peripheral blood itself. What we are now going to move forward is to see how we can transplant it. Groups have tried amniotic membrane, they've tried collagen sheets. What we are now moving forward is to try alternate approaches. So there's always different ways of belling a cat, and as with all research, there is a lot of progress, but setbacks are part of the game, like how we expected the eyeball to work, but it didn't. It's now reached a stage where we finished the first three things and we're looking at alternative approaches. And one thing being to try and use our existing DM or, denuded DM, which is already, inherent to that area, and use it like a DM scroll if you're able to grow the cells on it. Then move to animal experiments, which is the rabbit experiments, and clinical trials. Thank you very much for a patient listening.
Very nice study, Dr. Sharon.
Very nice. So many questions.
Can I ask you a question? So, do you see this method replacing, because it most likely would be used in endothelial diseases,
Yes.
where at the moment we are doing endothelial keratoplasties, and DMEC more than DSEC also is fairly like limited tissue which is being transplanted. The chances of rejections are fairly less. So, where do you see the potential of the iPSC sheets, if at all we are able to make the sheets and grow them on the DM scroll like you mentioned? Where do you see the potential switch that one could switch from DMAC to the use of these iPSCs on
Yeah, so
DM?
the biggest challenge is always with the shortage of tissue. Okay, obviously the technical, so we are looking at two things. One is just injection of the cells, just like how Dr. Kinoshita has shown, injection of the cells and then seeing how they grow as a sheet. And we're looking at growing them as a sheet outside and putting it in. Okay, we're going to be comparing both methods. So in this, we have just put in the cells. Okay, and it is still attached. Okay, but we have to see how it will do in the animal experiments and in human. Right? But we are looking at the sheet. So definitely there is a potential for it to replace DMEC, but how soon is always a matter of challenge. But yes, that is the idea, that we won't have to rely on the availability of a good corneal tissue. We can grow it in the lab, and because the biggest advantage of it is because it is peripheral blood. And there is so much of it available. It's a small sample that we have to collect. It's not a large amount. It's not like a blood donation. It's hardly 5 ml or 10 ml at max that you have to collect for it. So it's a very small thing, and it can be expanded so much. Because whereas with the corneal endothelium, we are already short of cornea. Then you need some more cornea to try and expand it. Plus, the endothelium doesn't normally have that expansion potential because it pauses in the G1 phase. So there are challenges there which we are trying to mitigate. And secondly, a problem of endothelial mesenchymal transition, which is very common with when we are doing from a corneal morphology. It doesn't happen with the blood cells.
And are there any steps that you are taking to maintain that microenvironment for, I think you showed it for 1 week.
Yes.
So how is it maintained for 1 week in the same kind of temperature? And
yes, so it's we have to put it in an organ culture media, which is the DMA medium. The reason we kept it at 7 days, so we had an experiment where we also kept it for longer to see if we'd get more markers and better markers. But what happens is that the cornea sort of proteolysis starts and stops. So in the organ culture media, we managed to keep it for 7 days. You have to maintain the temperature, the pH, and we keep replenishing nutrients to it at regular intervals every day, usually twice a day.
Okay.
In this experiment, we have not used any rho kinase inhibitor, because although we know it will help, but we want to see just how much potential is there just from the cells itself. But definitely we'll be going forward.
okay. That's all from me.
Thank you.
Thank you.
So I think next will be Dr. Rohit Band. Dr. Ashok Sharma is not here. So we invite Dr. Rohit Band for his paper, Long-Term Results of DALK versus Penetrating Keratoplasty.
Thank you. So it was a study of how the graft survives the traditional technique of a penetrating keratoplasty versus DALK, and this was a study of almost like more than 10 years. So coming to the history, it was Edward Ziem who performed the first penetrating keratoplasty way back in 1906. In 1920, Elshnik, he reported the first clinical series of corneal transplants, and he reported another series of 174 confirmed partial PK. And what it means by partial PK was the lamellar transplants, which we eventually called it. And Frito, he reported 800 grafts from 1920 to 45, and he started to use the cadaveric corneas. So what was this study about? The aim of the present study was to retrospectively analyze the long-term graft survival in a cases of a penetrating keratoplasty and a deep anterior lamellar keratoplasty or DALK. So how did this study go about? The primary grafts of DALK or deep anterior lamellar keratoplasty, which were 114 eyes, and a penetrating keratoplasty, which was around 187 eyes, performed for optical indications, were analyzed retrospectively. The primary outcome measured was graft survival time. Kaplan-Meier survival plots were used with a Mantel-Cox log rank test and used to compare the survival curves. This is just a photograph of a sort of a rectangular graph which was used in the initial days. So coming to the results, the 10-year survival rate was around 93.9% for DALK and 72% for a PKP or a penetrating keratoplasty. The post-op complications were obviously higher for penetrating keratoplasty as compared to DALK, like a presence of a glaucoma or allograft rejection and epithelial issues. The rate of graft survival attributable to rejection, the rate of graft failure attributable to rejection and endothelial failure were lower in a DALK as compared to the PKP, that is in a range of 36.7% versus only 5.9% PKP versus DALK, and the endothelial failure was 36.7% in cases of a PKP and 5.9% for a DALK. Now this is a graphical depiction of a 10-year graft survival. In a DALK graft it was more than 90%, while in a PKP graft at the end of a 10 years or something it was somewhere around 72% as initially discussed. So the coming further to the results as such, this is again a graphical depiction of how did the graft in the case of a DALK and PKP did. You have a blue blue diagram which shows the presence of a glaucoma, the epithelial issues in orange, and a grayish showing the allograft rejection rates. As you can see, those issues were lower in a DALK eyes as compared to that of a PKP eyes, and it was drastically different, like in a glaucoma was very high in a PKP eyes. So the severe complications of penetrating keratoplasty, we all knew the suture problems and the wound healing problems, and obviously with even severe or a trivial trauma could lead to extensive hemorrhages, and retained suture filaments could also lead to endophthalmitis. So compared to that, with the advanced keratoconus and apical scarring, how the graft looks like, it looks like a very pristine clear cornea, and the interface issues could be very less if you could go down very well up to the Descemet's level. So coming to the advantages, it has a lesser chances of rejection, longer graft survival, the globe integrity is better, and you could also achieve a faster visual rehabilitation as compared to a full thickness grafts. At the same time, what could be the disadvantage? It could be of a penetrating keratoplasty, it could be a compromised globe integrity, being a full thickness incision, the higher chance of graft rejection and obviously failure, the higher chance of secondary glaucoma, and a longer time of visual rehabilitation that is seen in case of a full thickness grafts. So to conclude, the 10-year graft survival for DALK was superior to that of a penetrating keratoplasty. The primary DALK results in a significantly less post-op complications and lower rates of graft rejection, and the study strengthens the case in favor of performing DALK over penetrating keratoplasty whenever possible. And this was studied not only for the keratoconic patients or dystrophy patients, but obviously the patients with superficial stromal scars as such. Thank you.
I just wanted to ask one thing, that this DALK versus PK in general you're making a comparison, not specifically to indications.
Not really. Any patient who had we had undergone, like this was a retrospective study, and whatever we had done where the full thickness graft was done and where a full DALK was done, we're just comparing the graft survival. It was not for any particular indication of a keratoconus or a dystrophy or anything else.
Scar, corneal scar, viral.
You have a nice long follow-up retrospectively. 10 years is a big, so good series.
Thank you, ma'am.
The graft diameters would have been different then, since the indications were all different. Was that something that you
obviously in a cases of a
into account?
keratoconus or in a cases of a scarring, the graft diameters were different. Those were not included in the part of this taken into the consideration, but
Yeah.
obviously depending on where your cone location is or where your scarring is present, or the graft diameters is going to vary. Yes.
because that also affects the outcomes in a
Ultimate
lot of
survival.
ways. Okay. ठीक है, nothing from me.
Now we would like to invite Dr. Maria for correlation of central corneal thickness with type 2 diabetes mellitus in a tertiary care center.
Good afternoon. My topic is correlation of central corneal thickness with type 2 diabetes mellitus in a tertiary care center. No financial interest. Introduction. Corneal thickness is associated with various factors like age, race, sex, and systemic diseases such as diabetes mellitus. Diabetes mellitus is actually characterized by chronic metabolic stress caused by hyperglycemia, which alters the corneal epithelium, stroma, and endothelium. In diabetes, the corneal endothelial dysfunction and increased corneal hydration generally affects the corneal thickness. The primary role of pachymetry is to act as a gauge of the corneal endothelial cell layer function. Thicker corneas are less compliant owing to an overestimation of intraocular pressure. The aim of the study was to determine the association of central corneal thickness in diabetic patients with and without retinopathy and compare it with age and gender matched healthy controls. It was a case control study with a study duration of 3 months. All patients with an age group of 40 to 65 years diagnosed with type 2 diabetes mellitus were taken, and they were subdivided into 3 groups, as subgroup 1 as patients with no diabetic retinopathy, subgroup 2 as patients with non-proliferative diabetic retinopathy, and subgroup 3 as patients with proliferative diabetic retinopathy. Participants were classified as having diabetes if they had a self-reported use of medication or physician diagnosis of diabetes. Controls consist of age and gender matched non-diabetic patients. Exclusion criteria: any previous history of glaucoma, any laser treatment, contact lens wearers, ocular surgeries, and patients with high spherical powers were excluded. This was a sample size calculation. 76 diabetic patients constituted the study group and 76 were healthy controls. After obtaining Institute Ethics Committee and a written informed consent, the study included 152 eyes. In patients with asymmetric retinopathy, the most seriously affected eye was selected. A pre-designed proforma was used to collect the clinical details, and after assessment of visual acuity, anterior chamber depth by slit lamp examination, gonioscopy, and intraocular pressure measured by Goldman applanation tonometer, the central corneal thickness was measured using an ultrasound pachymeter, and the patients were subjected to fundus examination. Results. This shows the gender distribution, in which the overall gender was dominant as male, which was 51%, and the second graph shows the gender distribution between the two groups. The mean age for the cases was 54 years and the mean age group of the individuals in the controls were 56 years. This shows the proportion of various retinopathy, with 2 patients in the mild NPDR and 19 patients of moderate NPDR and 14 patients of severe NPDR were taken. PDR group consisted of 13 patients and 28 patients had no retinopathy. The intraocular pressure measured among the cases was 18.4, whereas in the controls it was only 13, and relatively the IOP was found to be high in the patients with PDR. This shows the central corneal thickness, where the mean central corneal thickness in the cases were high, and it was more significantly high in patients with PDR. Analysis. The demographic characteristics were similar, whereas the mean central corneal thickness was significantly greater in the study group. The mean IOP was also found to be significantly greater in the study group. Similarly, the mean central corneal thickness was also found to be greater. Discussion. In our study, patients with study group, that is with diabetes, had higher values of CCT. This accounts because of the hyperglycemia, which causes a thicker cornea. The underlying mechanisms may be like endothelial dysfunction, altered collagen cross-linking, which can lead to a falsely high IOP. Hence, presence of hyperglycemia is an independent risk factor causing an increased CCT. The subgroup analysis within the study population, the presence of retinopathy is associated with a more increase in the CCT. More severe the retinopathy, thicker becomes the cornea, which is evidenced by more CCT in the PDR and NPDR groups. Hence, the severity of retinopathy is another important risk factor associated with the measurement of CCT. When comparing to other similar studies who also reported that thickened central corneas and altered endothelial morphology in diabetic patients with background retinopathy was similar to our study, and also hyperglycemia is associated with a thicker central cornea in their studies in which patients were grouped according to the glucose level. Lee et al. Measured that the CCT of diabetic patients with normal fundus and background diabetic retinopathy was found higher when compared to patients with the control group. Oshitari et al. Also found the effect of chronic hyperglycemia on IOP in diabetic patients and found that the levels of IOP was very high. In contrast, there is also studies which show that the CCT in diabetic patients was not different from that of the control group, and they also reported no association between the disease duration, nor the level of retinopathy, nor CCT.
Conclusion: in our study, the hyperglycemia and the presence of retinopathy are two important factors which influence the thickness of central cornea and hence the level of IOP. Hence, while measuring the IOP in diabetic population must be approached with caution. One should think about the levels of blood sugar and the presence of retinopathy, and a screening can be done for the same. Limitations of the study was a small sample size. Specular microscopy of the corneal endothelium was not performed, apparently, which gives a potential insights on the underlying corneal thickening changes among individuals with diabetes. These are my references. Thank you.
So what was the HbA1c in your patient?
HbA1c was not taken into account, ma'am, because in our setting, the HbA1c was not taken for all diabetes patients who come to ophthalmo OPD.
Lost, I think. Can we have the next paper by Dr. Alisha Kishore?
Intraocular pressure post keratoplasty, it causes irreversible endothelial cell loss, which leads to graft failure, optic nerve damage leading to visual loss. The incidence of elevated IOP post keratoplasty has got a wide range. It ranges from 20 to 46%. Hence, the aim of this study was to determine the incidence, risk factors, and the clinical spectrum of raised IOP post keratoplasty. It was a prospective observational study in which 130 patients were included. The cases with pre-existing glaucoma were excluded. Post-keratoplasty patients over 18 years of age with an IOP of more than 21 millimeter after 1 week of surgery were included, and the IOP measurement was done using the standard Goldman applanation tonometer. So the indication of surgery, the best corrected visual acuity, IOP, the detailed slit lamp examination, the type of keratoplasty done, and any additional procedure done during the surgery were noted. The patient was followed up at 1 week, 2 week, 1 month, 3 months, 6 months, and 1 year post keratoplasty. So amongst the total 130 eyes, 38 number of patients underwent therapeutic keratoplasty, out of which 15 developed glaucoma. 72 eyes underwent optical keratoplasty, out of which 14 had raised intraocular pressure, and 20 underwent DSEC, out of which 1 developed elevated IOP. So the incidence of glaucoma post-keratoplasty was found out to be 23%. Amongst the therapeutic PK cases, 39% of the patients had raised IOP, 20% of the optical PKs had elevated IOPs, and 5% of the DSEC cases has high IOP. The mean best corrected visual acuity pre-operatively was found to be 1.8 plus minus 0.08 logmar. Post-keratoplasty in patients who had elevated IOP at 1 year follow-up, the vision was reduced, whereas those who had a normal IOP at 1 year, the vision was improved. The incidence of the elevated IOP amongst the various conditions was found to be 36% in perforated corneal ulcers, 24% in adherent leukomas, in 14% of the cases with PBK, 14% of the cases with failed graft, and 12% of the cases with ABK, they were associated with elevated IOP. The additional procedures which were done along with the keratoplasty, like the cataract extraction or anterior vitrectomy, these were associated with high intraocular pressure. So, in patients in whom only PK was done alone, 14% of the patients had elevated IOP. In those where triple procedure was done, 41% of the patients had elevated IOP, whereas in those who had in whom the anterior vitrectomy was also done, 45% of them developed raised IOP. So the most common cause of glaucoma was found to be in therapeutic cases peripheral anterior synechiae, whereas in optical PK and in DSEC it was found to be steroid induced. Now, with the advent of the newer techniques in keratoplasty and lamellar keratoplasty being done nowadays, the incidence of glaucoma post-keratoplasty is decreasing. The incidence of elevated IOP is more after therapeutic cases compared to optical and the lamellar keratoplasties. And the incidence found in our study, which was 23%, was consistent with what has been reported in the literature so far. 67% of the patient had a raised IOP of more than 21 at 3 months of interval, and the perforated corneal ulcer, adherent leukoma, PBK, failed graft, and any additional procedure which was done along with the keratoplasty, like the cataract surgery and anterior vitrectomy, they were significantly found to be associated with the elevated intraocular pressure. Now, the limitation of the study was that the terminology being referred to as post-keratoplasty glaucoma is difficult, because for a glaucoma we need all the three factors as a standard protocol, which is the raised intraocular pressure, the visual field changes, and the fundus changes. But it is not possible in all the cases of post-keratoplastic cases, especially when there is post-op edema, when there is scarring of the cornea, or if irregular cornea is present, to do the complete evaluation and the complete examination. And hence labeling it as glaucoma or just labeling it as elevated intraocular pressure was a difficulty. Moreover, the number of cases for endothelial keratoplasty were quite less compared to the therapeutic keratoplasties and the optical keratoplasties. So we concluded that de novo glaucoma is a sight-threatening complication of keratoplasty, and we need more careful monitoring of the raised intraocular pressure post-keratoplasty for therapeutic cases, and in all those cases where additional procedures are done. Thank you.
A nice compilation of 130 cases. But how did you check the IOP?
Ma'am, we have done using the standard Goldman applanation totometer only. That was actually the main drawback, because in certain cases we were not able to measure it properly. So that was the major limitation. But in the literature also it has been found that majorly GAT was only done as a standard procedure as of now, but tonopen is being used now, but still no standard way of measuring the intraocular pressure has been reported.
Okay. Anything? Okay, I think we are done with all the presenters for the session. 2 people are not coming. Yeah. So I think we are done. Thank you, everyone. Thank you for sitting and listening, whoever was sitting in the audience.